Good morning, Carolyn. No volume, no sound. So what I'm going to do is I'm going to pull up the questions. And let me see. And anyone who wants to ask a question in the chat, please do it. Because Carolyn has no audio. So the first question is, I am slightly titrating my estrogen up. I am, however, finding that I am bleeding now every 2 weeks. My estrogen levels done via blood are 28. I do take progesterone. I'm being told 28 is too low. I was at the 28 level too when I was in perimenopause. I'm not sure what to do. I do not know if I should raise my levels or lower them. I do know that I'm completely miserable within all the symptoms of menopause can bring with it, and I am pretty lost. I appreciate your attention and thank you. And would someone in the chat tell us whether they can hear me? Can you hear me, Carolyn? Okay, good. This is one of these situations where there's a certain amount of information, but there's not enough information to really address a challenging time. And often what happens, and I don't know what this particular questioner's situation is, but often what happens is you're either working with a healthcare provider that really understands menopause, really understands compounded bioidentical hormones, has got some real good education and experience in it. And all we do at that point is take the next step and sort it out, because there's hardly ever a situation that if you just don't put your shoulder to the wheel, so to speak, and get down into the details, where you don't figure out and make the adjustments and things are good. And so I'm sort of thinking that you're with a more common situation where the provider has some experience but doesn't necessarily know how to work out the challenging cases. I invite your provider to contact me directly. I would be happy to help your provider with your situation, and because there's a lot more details that need to be known. But I am going to answer your question. Well, I'm going to back up a moment. This is every woman's challenge in the perimenopause and menopause. It's the number one job and often the only job you really need to succeed at, and that is finding a healthcare provider that really loves menopause and compounded bioidentical hormones, has got some education in it, is getting some experience, has a bunch of experience, is getting mentored in it. They're going to know how to sort this out, and that's your number one job. And you'd think it'd be pretty easy. I mean, if you want to find an orthopedic surgeon in your town, or a urologist, or an internal medicine doctor, you're going to find 10, 20, 30 if you're on, and not only that, their training is excellent. They've gone to medical school, they've done internships, and they've gone to specialty training and residencies. These are 3-year programs. You get a lot of information in these programs, and you get personal mentoring by an experienced staff physician. So the education is so uniform throughout the United States that you can pretty much go anywhere and find 10 orthopedic surgeons that are very, very good at what they do. But you can't find that in menopause, because menopause treatment took a body blow with some false information that exploded upon the public in 2002. in the form of a medical study that declared that there was increased risk, it actually didn't even do that. The press got a hold of a line in there and missed the line that says it was statistically insignificant, which in medicine means there is no information, there is no basis to form any kind of opinion, but it exploded out. So healthcare providers and women all over the world got frightened to be taking hormones. And although there was 18 million women, American women, 40% of those in menopause, were on Premarin and Prempro at the time and benefiting from it, it dropped to the way low millions with really egregious consequences. So the whole field of treating women in menopause has been stunted, but it's recovering. Our organization, IOBIM, the Institute of Bioidentical Medicine, we got a big team doing great things, educating physicians, nurse practitioners, PAs, and advising or prescribing compounding pharmacies. And so we keep getting more and more providers, so you can always check with us, or you can check with your local compounding pharmacist and say, you're getting prescriptions for compounding bioidentical hormones. Who in our town is really the most knowledgeable and experienced? Because they're going to know. And this is your job, because you're questionnaire, because you're asking some pretty basic questions here. For one thing, just assessing hormone levels by blood immediately tells me there's issues. The two most prominent traditional medical societies in the menopause field, the North American Menopause Society and the American College of Gynecologists, does not recommend doing blood tests because it says there's a high propensity for inaccuracy. Well, they're right. Because for one thing, when did you take your last dose? When you apply something to your skin or you take something orally, it comes into the blood and then it leaves the blood and it gets dispersed to the tissues. And you're not getting an accurate measure of tissue when you're doing blood. I've done thousands of blood tests for a lot of different things, and I learn a great deal of great stuff, but not for hormones. The only one hormone testing that I'm willing to stand behind at this point is 24-hour urine hormone testing, 24-hour urine hormone testing, not spot testing. We do have a study underway in which we're comparing the various methods through friends and family and patients. We're splitting samples, and I'll have more to report to you on that probably in a couple months. But right now, the hormone testing I recommend is 24-hour urine hormone testing, and so it matters when your blood was drawn. Like, was it drawn in the morning and you took your last hormone dose the night before, or you didn't take it? So I don't know what 28 means, because things are very evanescent in the blood. That means they come and they go, and they get into the tissues. Now, the biggest clue that you have here is this bleeding. And when I see someone who is bleeding, I always go to the bottom line. Is the bleeding a problem? And the specialists who are great at bleeding are the gynecologists. And the very first thing that I would want in this case is a gynecologic consultation, where the gynecologist, and they all have them, would do a transvaginal ultrasound. They take a look at the lining of your uterus and make sure the bleeding is just coming from a thickened endometrium, which is no big deal, or it's coming from something in the uterus that doesn't belong there, like a tumor. And they're not that common. In 28 years of dealing with women, I've only seen 2 endometrial cancers, but it can happen. But what is more common is a fibroid. And if a fibroid is sitting there in the lining, it can cause bleeding. So the main thing is you want to find out what that bleeding is from. And when you don't know what it's from, and you've gone a long time since you were menstruating, like a year or 2 or 5 or 10, and all of a sudden you're bleeding, we want to know what that bleeding is from. Now, very often looking at the dosages that are being used, I can tell whether the dosage is excessive, and so that the bleeding could be coming from that. But the bottom line is transvaginal ultrasound, a gynecologic uh, consultation. Oh, everyone loves to go to their specialist. Gee, how quickly can I get there? You know, no, but we want to take advantage of these really well-trained folks. They know how to track down bleeding. You know, they can even do a biopsy in their office if it's necessary. So that's your main job. Is you need to seek friendly and gynecologists to evaluate that bleeding. Many times, the highest percentage of the time, we see that the bleeding is not coming from a problem. It's coming from an overdose. Well, how in the world could you possibly have symptoms of menopause and be on an overdose? Here's my answer. You can easily get symptoms of menopause on an overdose. I found this out the hard way. I can picture the woman. Her name was Laura, and it was a long time ago when I was a beginner. And she was in her late 30s. She had a premature menopause, and she had terrible hot flashes, life disruptive, sleep disruptive hot flashes. So I started her on a common dose, and it wasn't quite doing the job. So I taught her how to increase her dose slowly and keep on increasing until she alleviated the symptoms. But I did not give her a ceiling. And there came a time where she took matters into her own hands, and she kept on increasing the dosages, and I didn't hear from her for quite a while, and then I finally heard from her, and I listened to the amount of hormone that she was applying, and I went, oh my goodness gracious, great balls of fire, this woman is on too high of an estrogen dose. And sure enough, that was it. She had just titrated herself up to an excessive dose. And here's how things work when you're taking a medicine or a hormone. There's something called the therapeutic window. It's a dosage range that you got to get at. If you do too little, you're going to have symptoms of hormone insufficiency, hot flashes, etc. If you have too much, you're going to get the same thing. You got to hit the therapeutic window, the right amount for your body. Now, there's ways to explain this. These hormones, they're working with receptor sites. So you've got your hormone, you've got your receptor site, and the hormone goes into the receptor site and does its thing, and then it leaves. And that's how things work. But if you've got way too much hormone, it goes into that receptor site, and by a law of chemical mass action, it stays in there, and you get no hormonal effect. Doesn't matter what the mechanism is, you can easily get a hormonal overdose and get raucous symptoms of menopause, hot flashes, etc., etc., etc. The 28 doesn't help too much. You'd think that we'd be able to tell if you were on a chronic overdose, but I would want to do a 24-hour urine hormone test. But first, I'd want to see what dosages you were on, and first, I'd want to check out the cause of that bleeding. If you were obviously on a humongous overdose, I'd say let's stop all the hormones. And here's a very interesting thing. If a woman's on an overdose and she's getting raucous hot flashes, and you stop the estrogen cold, which you can do, it's not like stopping a blood pressure medicine cold. You don't do that. There's some medications, you don't stop them. If anything, you gradually wean someone off, but you do so very carefully. But hormones, you can stop them cold. And if day 1 of stoppage, day 2 of stoppage, she's still having hot flashes, she still feels miserable, and this is just an example, on day 3 of stoppage, she starts feeling better, you know she was on overdose. And if you keep on stopping and she feels better for a couple days, and then she starts getting hot flashes again, you know what happened. She was on an overdose, and when you stopped, her tissues started letting go of the extra estrogen it had. And there was a moment in time when she was in the therapeutic window just from her own body. I don't know if you understand that or not, but my main point is number one, gynecologic referral to check out the cause of that bleeding. And if it's just a thick endometrium, that's all that's going on, then you can experiment with the hormone dosage levels. And you need a provider who really understands how to troubleshoot things, because the human body's complex and there's a lot of moving parts. But to someone who's spending their career caring about it and learning about it and getting a lot of experience, they know how to go through the sorting out process. And that's what you're missing primarily. A gynecological referral to make sure that nothing untoward is happening in that uterus. And once you get the clearance from that, someone who knows how to sort this out. And healing is possible. I can't, anyone who's stuck with me, there has not been an issue in 28 years that we didn't figure out something. And sometimes it took a year or two. But that's my recommendation. And Carolyn, yeah, no voice.
Can
What
you
the
hear
heck?
me?
I can hear you.
You see, I have those bewitched magic powers. I just did my little, you know,
Excellent.
and here we are. I don't know how I did it, but I did. Thank you.
So why don't you pick up from here?
Well, I really like hearing you better than me, but I'll do that. Okay, thank you so much for that answer, and thank you for your kind patience, and thank you, ladies and men, for your kind patience too. We go on to question number 2. And it says from the questioner, I have been on biased progesterone, testosterone, and DHEA now 4 years. Via CAT scan and DEXA scan, I am told that my bones are awful and they're weak. I'm 65 years old, and how can this be after 4 years of taking these virtually daily? I feel horrible weakness in my thighs, not leg cramps, but weakness. Have you ever heard of this? Or is there any advice that maybe you could give me that I can take a hold of?
Yeah. Well, there's two issues here, the bones and the muscles. And once again, this situation needs to be troubleshooted, troubleshot.
Shut.
Someone who's, I'm just repeating myself from the first questionnaire, someone who has really taken on treating women in menopause with compounded bioidentical hormones, got the educations, getting the mentoring, getting the experience. They know how to go through a process of trying to figure out what the heck's going on here, because something's going on. And the bones. I really am very, very uncomfortable for a woman to be told, or a patient to be told, that her bones, what was the comment, Carolyn? Her bones are shot or something?
No, not shot, but she says I've been on bio blah, blah. She says that she was told her bones are awful and
Yeah,
weak.
that's a real bother right there.
Well, it's suggestive. It's
um,
something
I
rather.
never, I really just recoil at people being told that, because we're all sensitive, and there's the whole subject of osteoporosis needs to be understood, and the details about what contributed to bone stabilization and even bone replenishing, that needs to be understood. So one thing I'd recommend is that you download a copy of our book, and there's a chapter on bone health there. And there's a lot of moving parts to the health of bones. Now, here's a common situation. I don't have enough detail, once again, to really know what's going on with this patient, but it's common for a woman to go in menopause and not be treated with hormones for a year or 2 or 3 or 4 and 5 years. And this is a magical time. This is where the estrogen really matters the most. And this is where a lot of the severe bone loss takes place. So I don't know when she started treating, and I don't know what her numbers are on the DEXA scan, on the bone scan. But sometimes what happens is you run into a situation where a woman didn't have hormones for quite a period of time. She lost a lot of bone, then she starts getting treated with hormones, and she stabilizes. And the comment awful doesn't help. She could be stable and she could have enough bone health that she's very unlikely to get at risk. And if all the moving parts that lead to bone health are attended to with precision and individualization, she can even get some bone replenishing. Now, as you'll read in that chapter, when a woman has severe bone loss, one of the first things we do is a test called DPD. You can do it through blood or urine. It's deoxypyridinolone, because bone is a very active organ, just like all of them are. Your body knows how to break down old bone and reform new bone, and it has actual cells dedicated to this purpose. It's got osteoblasts to build up new bone and osteoclasts to break down the old bone so that the new bone can be rebuilt there. And when there's too much bone loss, we get to see in the urine or even in the blood some of the biochemicals that are released from too rapid a bone breakdown. So the very first thing that I do is I do this DPD, or deoxypyridinolone. I like doing it in the urine, and see if there's too many bone metabolites in the urine, which means the process of bone loss could still be active, is still active. If you have a very low deoxypyridinolone, there's not a superactive bone loss process, and there's very likely, if the hormone dosages and the other things that relate to bone are all in place, that you're going to get bone replenishment over time. And so read that chapter on bones.
I just reposted Happy Healthy Hormones again. So it's
Great.
yes.
And you can see there's more to the story than just hormones. Hormones are a principal player. And then I highly recommend, you've heard it from me many times, the use of the 24-hour urine hormone test to assess hormone levels, because in a woman who's got bone loss, hormones are so involved. Like estrogen slows down the cells that break down bone. And if you lose your estrogen, those cells get more chomping power and they break down the bone faster. That's how one of the major losses of bone in a menopausal woman. Progesterone is the only biochemical I know that supports the cells that lay down new bone, the osteoblasts. Testosterone affects bone, DHEA affects bone, thyroid affects bone. So we want to do very accurate assessments of this, and you're going to need the 24-hour urine hormone test to assess the 4 ovarian hormones that are relevant, and you're going to need blood testing to test the thyroid to make sure that it's okay. But as you'll read in that chapter, there's other things that need to be assessed. If your diet or your stress levels are producing an acidic metabolism, as stress biochemistry does, or as dietary indiscretions do, very capable of producing too much acid in your body. Well, how does your body protect itself from too much acid? Because it does not like too much acid. Well, it uses buffers. And some of the best buffers around in the long haul are the minerals. Well, where does it get the minerals? From where the minerals are living, in the bone. So you really want to pay attention to acidity. So there's ways that I describe in that chapter on how to assess your acidity. And then bone's made out of protein and minerals primarily, so you got to have it in your diet, and you got to be able to digest it and absorb it. And yes, the parathyroid does affect the bone, so that's one of the things that you can check too, because there's people with parathyroid tumors that can have bone issues as well. There's someone who knows how to take on osteoporosis, and the details of it will include parathyroid as well. High cortisol levels from high stress levels will melt the bones. So there's a lot of moving parts, and once again, your job is to find someone who really loves this subject called menopause and treating women in menopause with compounded bioidentical hormones and loves the 24-hour urine hormone test. You need that much.
Well,
And
please continue.
so this, because it could be that your bones aren't awful, that they're fine. And the other thing I want to address is that muscle pain. And I didn't have enough information there. It's the weakness told me that the weakness can come from a variety of things, including some medical conditions that need diagnosis from someone who really understands this. These are rheumatologists are more likely to understand this. Neurologists are more likely to understand this. But you always go, are you just losing muscle? Because if your thighs have gotten thinner, and you used to be able to stand up from a chair without using your arms or get off the ground without using your arms, you got muscle loss. So you can check your tricep area and just give it a twang there and see if it's flab, because that's a common place that women lose muscle. They lose muscle all over the place. If there's muscle loss, the main tool you have is testosterone and DHEA, the androgens, and they're critical. And so getting testosterone correctly, the dosages correctly, really matters. And you're not going to be able to know if you got it correct unless you're doing a 24-hour urine hormone test. People will, some people working in the field of menopause will debate me on that. They'll say that other testing methods work. I cannot support those other testing methods with what our experience is. But we're testing it out. We're cross-checking. We're sending in split samples on several people, including myself, to see how these other laboratory tests stack up. Now, when someone has bone loss and muscle loss, I love to optimize the 4 ovarian hormones, testosterone and thyroid. Testosterone is included in the ovarian hormones. And I like to use robust levels, not excessive levels, but I like to get robust about it. And I like to get really rich levels of progesterone because they help you lay down new bone. So there's a process that we describe in the book called dosage determination by symptom alleviation. And then once you alleviate your symptoms, you don't have menopausal symptoms anymore if you had them in the first place. Then you do the 24-hour urine hormone test, and we know our numbers. So we know when someone's running lean, that means someone's got osteoporosis and sarcopenia. That's the technical name for muscle loss. And we can see that their numbers are low, even though they're being treated. And this is very important because I once did a study. I took of the preceding year, I took 54 24-hour urine hormone tests of women who said to me, I feel good. I think all my symptoms are gone. And I said, great, let's do a 24-hour urine hormone test. And here's what I learned, that 50% of them, they felt good, their hot flashes were gone. 50% of the women that I tested, of those 54, did not have adequate ovarian hormone levels to protect their bones, their vagina, their bladder, etc., etc., etc. They were on insufficient dosages. They felt good. They thought symptom alleviation was all you needed to do. No. The answer is no. You
Well,
need
was
to
it a waste of time to be taking at least
no,
that?
no, that's taking something is good. But the purpose is once you learn that you were on inadequate dosages, your next step is to boost those dosages in a guided fashion by a provider who really understands how to do that. We're training providers all over the United States, so you might want to check with us to see if we have someone in your area. And you want to optimize slash maximize your all of these ovarian and thyroid levels because these are powerful biochemicals and they all relate to bone. They're not the only thing that relates to bone. So read that chapter on bone health because you got acidity to deal with, you got stress to deal with. It turns out that stress biochemistry is bone melting. Holy mackerel. Fight or flight melts bones. And I'm not saying go out there and eliminate the stress in your life. I'm just saying get skilled at dealing in a safe way with the fear, the sadness, the anger, the shame, the guilt, the other uncomfortable feelings. Get some skills and some knowledge on how to deal with it in such a way that you don't have to trigger the full blown biochemistry of fight or flight because that's really important. And because you don't want to be producing bone melting stress hormones because that's what they do.
Oh God, no. And they're
So there
they're
you go. There's an introduction to bones. And again, main job, this woman needs to find a provider that understands all these stuff, understands all these moving parts. You can help the process by reading the book, but you want to meet up with a provider who knows their stuff, and they'll sort it out for you. I've seen a lot of bone density tests that were not pretty. But the women were doing fine, and the bone density does not talk about bone strength. Of course, osteoporosis is most likely going to be a less strong bone. But you take precautions when you've got osteoporosis. You no longer ride horses, for example. You don't skydive. In
oops.
fact, you learn ancient martial art that's something like Tai Chi that really helps you get more present in your body. And when
Mm,
you're walking down the street, you're paying attention to your body. So you're not tripping and falling. You're paying a lot of attention to your body and you don't take unnecessary risks when you've got osteoporosis. You're paying attention to curbs and stairs. You're not walking up the stairs and thinking about what you're going to have for dinner that night. You're walking up the stairs and you're paying attention to the stairs. Because if you don't fall, even with osteoporosis, you're going to do good. Maybe not perfect, and there are instances where it does get problematic. But for most women, even if you got osteoporosis, all you got to do is not fall. So, when was the last time you took an accidental fall? And if you are taking accidental falls, you want to take on a discipline that gets you more in your body and more present in your body. Like one thing I learned from Tai Chi is like when you're walking down the street, what do you have? You've got this miracle of being able to walk. And the pleasure is going to be in feeling your body and paying attention to where you're walking. And not thinking, talking. No, you're paying attention to the walking. And if you do a good job of that, you're going to have more pleasure walking. So that's a practice that I do when we walk is I'm paying attention to my body and I'm feeling the miracle of my God, my legs are moving and my pelvis is tilting one way and the next and I can feel it and I can feel the great pleasure, the great pleasure of walking and the privilege of walking. And I'm paying attention. pretty rare that I'm going to trip, and if I do, it's going to be a very minor thing because I'm paying attention, knock on wood.
Oh, yeah. Hmm.
So if you're unstable and if the weakness in those lower extremities, best case scenario, that's muscle loss from inadequate testosterone and DHEA levels. Best case scenario. So you can rebuild that, and you can rebuild it with exercise plus the androgens. You're going to need the hormones. You're going to need the hormones to rebuild that muscle. But in the meantime, if you are unstable, there's this old fashioned thing called a cane that increases your stability. And it's well known amongst many cultures that the elderly sometimes choose that cane because if you've got osteoporosis, you want to be stable, especially while you're healing your sarcopenia. And is sarcopenia healable? Well, let me tell you the story of my mother-in-law, Blessed Mary, who's no longer with us. She was in her late 80s, and she'd reached the point where she was using a walker because she could not walk with stability, but she was standing in her kitchen and she turned in one direction and fell onto a tile floor, fractured her shoulder, her humerus, that's her upper arm bone, and her pelvis, and was in rehab for 3 months. She had osteoporosis galore. She also had sarcopenia, so that's why she was just enough weak that she needed a walker for the stability. Well, we have a video in our archives after treating her with androgens, with testosterone. We have a video of her sitting on a low couch with this huge smile on her face, arms raised up and standing up from a low couch. That's the restoration of muscle strength that she achieved by about 3 months of good testosterone treatment.
It's a beautiful story. I always
Yeah.
love when you tell that story.
And she was a beautiful human being.
Yeah.
I have something she wrote me on my desk here because she was always my favorite patient of all time. I've had a lot of people, and so at any rate, there's a lot of moving parts, and it's worth taking on the study. But I'm not going with the awful technique. If you're still walking and you haven't fractured anything, we don't know. You just need to implement all the things that I described here, including being careful. And bones do replenish. They get stronger. The very first thing we're looking for is stabilizing bone loss so that there's no more bone loss. And that DPD test, deoxypyridinolone, it took me quite a while to be able to pronounce that thing, so I'm very proud.
Like feng shui?
And so, yeah, you need that test to see if you're still actively losing bone. And if you are, that chapter on bone health will be a doorway to you learning what in the heck's going on there. Next question.
Thank you, Dr. Rosensweet, for that answer. It's a good answer. And I, again, always love the story about your mother and the story about your mother-in-law. Beautiful stories. Question number 3. Since taking hormone therapy, progesterone, testosterone, and estrogen, I have noticed my hair getting really greasy, even one day after washing it. I'm also noticing nodules, of all things, in my scalp that come and go. Could this be hormone related? And if so, what can I do about this? Thank you so much. And that would be for both the greasy and the nodule.
Yes, it can be hormone related. Now, I'm not an expert on scalp nodules, and they may require the help of a dermatologist, but it could be scalp acne because too much testosterone will lead to greasy hair growth in places you may not want it to grow, like your mustache area or your chin, and greasy skin. So I've always been amazed by someone being disturbed by oily hair because Oily hair is a beautiful thing. It's so healthy for the hair.
Yeah.
For now, are you on too much testosterone? That's the one I would be looking at. Well, you do a 24-hour urine hormone test, or you back down on the testosterone that you're on to where you're not getting the nodules if they're actually acne pimples taking place in your scalp. Sometimes you need the help of a dermatologist. The fact that those nodules come and go is very promising. But the greasy is from excessive testosterone, most likely. I'd celebrate the greasy, but I would get a 24-hour urine hormone test to see if you're on too much, or back down on the dosage of the testosterone you're on to where it's not excessively greasy. I'm surprised you don't have other symptoms that you mentioned, like facial acne or acne on your back, pimples, or oily skin, excessively oily skin, or hair growth. But yes, it would be one of the first places that would want to explore with that symptom of excessively greasy scalp is, are you on too much testosterone? And you can find that out by a 24-hour urine hormone test.
Yep. Yep. That great test. 24-hour urine test. Good. Just side note, like how how long do you have to be on hormones to do the 24-hour urine test? Could you do them in like 2 weeks, 3 weeks of just
Well,
starting?
I like to test women if they haven't been on hormones before. I like to wait until their dosages are clinically dialed in, which means their symptoms are alleviated and they feel good. And that takes place usually by the third to sixth month, somewhere in there. That's when we like to test them. If a woman's been on hormones and she's on steady dosages, do the test right now. Or reduce the testosterone some and see if the excessive oiliness goes away, or at least the bumps. I don't know that there's excessive oiliness of the scalp. It could be a sign of too much testosterone. There's other symptoms of testosterone excess, and in the book, there's this card which lists symptoms of excessive testosterone. I'll read them to you. Hyperaggressiveness, excessive oiliness of the skin, increased pimples, acne, increased hair growth on the body, face, and or place of application. So irritability, too testosterone-ish, there are symptoms. If there were obviously other symptoms of testosterone excess, I'd reduce the testosterone and then do the test. So you want to be steady on your dosages for at least a week. You want to be religiously accurate when you're doing the 24-hour urine hormone test for at least the preceding week. And of course, you take your hormones during the 24 hours of urine collection, because then we get to see what's going on in your body.
Yeah.
You never want to omit the hormones during the urine collection time, which people
Right.
do all the time. You want to be taking those hormones just like you always do. So this woman has been on hormones, so she could, so long as she's been steady in her dosages, she could take the test anytime.
Well, that's a good answer because a lot of times women feel that they have to, on the day of testing, not take their hormones at all.
Yeah, that's
Mhm.
a big mistake.
Yeah.
We don't learn anything of value. One of the whole purposes of the 24-hour urine hormone collection is, when you're taking your hormones, we get to see how much hormones in your body. If you omit the hormones, we don't get to see how much is making it in your body.
Right.
So, but the issue comes up periodically, and I'm glad we get to talk about it. You want to be taking the 24-hour urine hormone test at a time when you're symptomatically stable and when you've been religious in your hormone dosage taking for the week before, and you continue taking all your hormones just as you usually do, religiously, during the 24-hour urine collection period.
Got it. Okay. Well, thank you. Thank you for that. Um, question number 4 comes in saying, I take hormones. I take bias, progesterone, testosterone, DHEA, and at first I felt fabulous and for quite some time. But now, out of nowhere, I have no energy at all. I felt so great. My 24-hour urine tests were great. Yet, for whatever reason, now I do not have any energy. Um, my regular blood work from my primary care provider is really good. I don't have anything going on there, but I'm wondering if Dr. R knows if he has any ideas as to why this could be and if maybe this is attributed to hormones.
Well, there's some really great news here. Um, when a woman has symptoms of menopause and then she goes on a hormone program and she feels great, that's living scientific evidence that her body knows how to put together the recipe to feel great and with the hormones. Now, we check in with women annually because from time to time we need to tweak things. And I mean, I can think of a lot of things. This is one of those situations where there's just not enough information. But the kind of information I would seek is what are the actual symptoms she's having? And low energy, well, if that's the main thing, I'd want to do a 24-hour urine hormone test right now. Plus, I'd want to do a thyroid blood test. And here's what I want in that thyroid blood test that's really crucial: a TSH, a free T4, a free T3, and a reverse T3. And the other thing I want is a sex hormone binding globulin. Because if it's the ovarian hormones that are awry, if the dosages were excessive or not really spot on, she's saying that her 24-hour urine hormone test was really good. In the instance of me dealing with an actual patient, I'd be able to see what those test results and see if I agreed with that. I don't know that I would agree with that. All the laboratories on the planet Earth, for a menopausal woman, for example, they compare you normal with, let's say you're 60 years old. Well, they compare you with your age bracket by the decades. So they're going to report your reference range as what's normal, a 60 to 69 year old. So you could show high levels for a 60 to 69 year old, but that's totally deceptive because you could be very low. So in the menopause method, we always ask our laboratory to supply us with the reference range of a 20 to 29-year-old, because that's when women have the highest levels. We're not trying to replicate 20 to 29-year-old levels, but what other decade can you compare it with? You don't want to know how you're compared to a 60 to 69-year-old because they're going to be at zilch hormone levels. So if you're taking hormones, you could show up as going, oh, it's terrific for a 60 to 69-year-old. I'm repeating myself there, but the principle is every menopause method provider is getting the menopause method report form from a certain 24-hour urine hormone testing lab, and we've requested, and the laboratory director agrees that the reference range that we use is 20 to 29-year-old. How do you stack up to that? And then there's all kinds of things that can go wrong. When energy is the principal thing, I'm repeating myself. I want to see what that thyroid's doing because, depletion of thyroid hormone is epidemic in the United States. It always has been. And for people to have not so much low thyroid that they would be classically hypothyroid and get that diagnosis, but to have less thyroid hormone than they actually serves them. It's called functional hypothyroidism. We
Mm.
can tell by their numbers. So that panel of free T3, free T4, TSH, and reverse T3 really matters. because thyroid is, when you're talking about energy, that's one of the first places we go. And you could get lower energy from imbalanced or overdose or underdose of the ovarian hormones. So, or you could, if you were on slight overdose of ovarian hormones or thyroid hormone, you can get an elevated sex hormone binding globulin, which will bind up some of those hormones. They'll be less effective. So this is where I would begin. But where I really would begin is I'd hunker down on the details of this woman's whole story. It's called a medical history. We have a 12-page questionnaire our patients fill out when they're new to us. And invariably there's clues in there. And we follow the bouncing ball. We see the clues. Like I look at the dosage levels, and I'm not saying this is going on in this patient. I go, look at this. These dosage levels are quite robust. She may have going on what we described earlier, that her levels were too much, and she's getting symptomatic from having too much. All kinds of possibilities, though. I don't want to single that one out. I want to say that someone who's really familiar with hormones and treating women in menopause with compounded bioidentical hormones is going to have a whole protocol on how to troubleshoot, on how to find clues as to what's going on, and then confirm those clues and then make the adjustments necessary. Because going back to what I first said, if there was a recipe that you felt great, we know your body is capable of doing that. So something's off. That's why we do an annual check-in with women. We do the 24-hour urine test annually. Sometimes we do the thyroid panels and sex hormone binding globulin annually, because these are the common things that can go get a little bit off. And sometimes you got something called dermal fatigue, and I don't know how you're taking your hormones, but it's common that if you've been rubbing your hormones on topically, your estrogen and testosterone, for example, at the minimum, that the place that you're rubbing them needs a break, and you need to switch places. So in the menopause method, for example, we advise that you apply the bias to your soft forearm right here. Rub them together. But sometimes that can get oversaturated in something called, Dr. Wright dubbed dermal fatigue. So you switch sites. So you start applying your bias to your posterior deltoid region. And all of a sudden you start feeling good again. And you go, look at that. I had dermal fatigue. And so
Right.
you learn how to rotate hormone application of the topicals. So there's a lot of possibilities, and that's what makes answering some of these questions challenging, because there's not enough information there. But that's okay. Her job is identical to what every woman's job is. It's the same job. You work with a healthcare provider who's got specific training in treating women in menopause with compounded bioidentical hormones, and ideally some experience. If they don't have the experience, then the best thing to do is to you find someone who's getting mentored and is involved in a training program. And here's a wonderful question by Michael. Why don't you read this?
Absolutely. Because the other one is going to take a while, and we have a few minutes. So, hi, Michael, and welcome. In reference to comparing hormone levels to that of those levels in a 20 to 29-year-old, is the goal to treat the patient until at a comparative level of a 29-year-old?
That's an excellent question. And Michael is a doctor of pharmacy. He has his doctorate in pharmacy.
Mm-hmm.
Um, the most global answer to that is no. We are not trying to replicate hormone levels of a 20 to 29-year-old. And I want to elaborate on this because this is a very important question. A young woman, a 20 to 29-year-old who's healthy, she's going through a menstrual cycle in which many things are happening. And one of them is she's preparing for possible pregnancy. Her uterine lining proliferates. And believe it or not, I know Michael knows this, but believe it or not, she's also preparing for breastfeeding every single menstrual cycle. And in doing so, she's getting increased breast glandular cells. You're getting cell division, you're getting new and extra breast glandular cells. Mitosis is occurring there, cell division is occurring. And women know some form of this because very often a young woman will feel her breasts get fuller during the course of her uh, menstrual cycle. You know, from day 7 on, she can get fuller and fuller and fuller breasts because the estrogens are causing proliferation of the endometrial lining of the breast glandular cells. And if she does get pregnant, they go on to continue to proliferate and ultimately to prepare for breastfeeding as far as the breast goes. But if she doesn't get pregnant, she goes through a deproliferation where the new cells disappear by a process called apoptosis. Love that word. And this is what's going on in a 20 to 29-year-old. We don't want to replicate that. It's been beautifully expressed, and I have this in my book, Happy Healthy Hormones, that you could download. There's a reference from a gynecologist who really challenges these robust levels of dosages that are given not commonly to women enough to bring their period back. Says if they're high enough to bring their period back, they're high enough to produce breast glandular cell proliferation. Well, that's a vulnerable moment in the life of a cell, and
Yeah.
there's cell division taking place there, and we don't advise that for women in menopause, nor do they need it. So on the 24-hour urine hormone test that we use in the menopause method, there's the standard reference ranges showing what's too little or too much, what's common for 20 to 29-year-olds, and then there's an extra line in there, and it's called total potent estrogens. And as the asterisk leads you to the footnote, it says this is dosages were derived from the medical literature and describe what are optimal for a woman in menopause. And here's what it looks like. You can have some young women who are regularly menstruating, are fertile, and they need this much estrogen, so to speak. But other young women need this much estrogen to be healthy, fertile. That's a wide range. Well, that's how it goes. We're individuals, we have individual needs. Both of these women can be healthy, and all of the women in between can be healthy, menstruate, be fertile, get pregnant, etc. That's what it takes estrogen wise in a young menstruating woman. Well, what we determine for most, and not all women, is the optimal zone for treating women in menopause is just below the dosages of a young woman. That will protect her bones. That will protect her vagina. We know that from medical studies, and those studies are listed actually in our professional training program. So the answer, the initial answer, Michael, is no. 20 to 29-year-olds are the only useful thing I can think of comparing to, because as you get into the decade of the 30s, you're getting erraticness. And as you get into the 40s, you're starting to get into lowness and erraticness. In the 50s, you get into lowness. So what does that tell you? You could have a 60-year-old who's being treated with hormones, and it looks like she's doing terrific because the normal 60-year-old doesn't have any ovarian hormones to speak of at all. So if she's got any hormone, you could misread that and think, wow, she's doing great. When really she's not. She's on inadequate dosages because she's getting compared to a 60 to 69-year-old. It's very helpful to compare them to a 20 to 29-year-old, but we never are trying to replicate that, with an exception, and I'm going to get to that exception. Because the medical literature tells us, and I've extrapolated that to the 24-hour urine hormone lab, and this rigorous PhD who owns this lab and only does 24-hour urine hormone testing on ovarian hormones, he decided to get great at one thing. He accepted the reference ranges and is willing to publish it on his lab reports because he sees the integrity of the science there. And we know that to protect the bones, you need a certain amount of, well, we like to sum up the potent estrogens, estradiol plus estrone. They need to add up to 8 micrograms per 24 hours minimal, and don't go higher than 14 micrograms. That's the optimal zone for treating a menopausal woman. And interestingly enough, 14 micrograms, which we hold as the upper limit of potent estrogens for a menopausal woman, is where young women begin. The lowest the young women can go in her estrogen levels of the total potent estrogen is 13.9. Quite a coincidence right there. So these low levels for a young woman to be healthy and menstruate and form an endometrial lining, she needs at least 13.9. Well, that's the upper limit for women in menopause. I don't know if you followed that. In our professional training program, we go into great detail on this. Now, I did say there was an exception. I would like to say that optimal zone, 8 to 14 micrograms of the sum of estrone and estradiol per 24 hours, would cover everybody. Well, it will cover almost everybody, with very rare exceptions, to protect their bones from bone loss and to protect their vagina from vaginal atrophy. But what we're not talking about is, well, how much do you need if there's cognitive loss? Because estrogen can be really critical for the healthy functioning of the brain. And the medical literature points out very clearly that there's a certain number of women that you give them menopausal treatment levels of estrogen, and they're going to do great. If they've had some fuzzy thinking or some brain fog, they're going to recover. And they're going to be very grateful for that.
Oh, yeah.
There's a certain percentage of women that they need more robust estrogen levels. So now I'm going to retell this story that was very impactful to me. And it was about this gynecologist I know in Washington, D.C. She's 65. When I had lunch with her and her son, and she told me this story that when she was 55, she started to get cognitive challenges. And she's a practicing physician. And I want to tell you, it's an arena that you don't want to have cognitive challenges.
No.
Of course, there's every arena. Nobody wants to have cognitive challenges, but you certainly don't want to go to your doctor who's having cognitive challenges. And it was really disturbing her. And she had a genetic story there. Her mom and her mom's sister, thus this practicing physician's aunt, both had full-blown dementia. And it was scaring her. She's 55. She's in her medical office, and she's not thinking clearly, and she's thinking she's going to have to stop practicing medicine. But she knew about the estrogen connection to brain health. And there's a jillion, not exactly a jillion, estrogen receptor sites in the human brain. A lot of them are estriol receptor sites, estrogen receptor site beta receptor sites in the human female brain. And so she started taking estrogen. And after a while, she started to clear up. And she took a little more estrogen, and she started to get clearer. And she took a little more estrogen, and she started to get clearer. And she took a little more estrogen, and she cleared up entirely, and her period returned. Now, we know what it takes to get a period to return. It's a lot. It's usually 3 to 8 times the upper limit of normal of a young menstruating woman to get a period to return. But you never say never. And, I had tears in my eyes when I was listening to this story, because I'm a practicing physician, and I'm hearing that at the age of 55, she's thinking of having to give up her practice. That was and then she recovered her brain so much. And here we are having lunch, and she was definitely as sharp as I was at 65. So you never say never. It is not a common practice to replenish hormone levels to the youthful levels. And this was Michael's basic concern here.
Yes.
No way. In fact, we like to fall shy of a 20 to 29-year-old. The 20, and I'm repeating myself, but the 20 to 29-year-old who needs the least amount of estrogen, it adds up to be healthy and to menstruate, it adds up to, when you add up the two potent estrogens, 13.9 micrograms per 24 hours. Well, that's the upper limit of most women that we treat in menopause. But you never say never in medicine. And what do? You just amp up your breast care techniques. We have a whole chapter on breast health in my book. and you go through and you're rigorous in everything, including the diagnostic techniques, including an annual thermogram, mammogram, whatever it takes, whatever the radiologists are recommending, you're just scrupulous in your monitoring techniques, because estrogen does not cause cancer, does not cause cancer, does not cause breast cancer. Now, there's a lot of causes for breast cancer, so we're very cautious in creating breast glandular cell proliferation, thus mitosis, in a menopausal woman. But no, we're not trying to replicate the 20 to 29-year-olds. No way. In fact, we fall just below their lower limit of normal to be able to menstruate. They need enough estrogen to menstruate. And for those who need the least amount and be healthy, that's the most amount, that's the maximum amount we recommend for treating women in menopause. And like everything in medicine, there's exceptions. And that physician, bless her heart, Wanda, it's her first name, it took so much estrogen that her period came back, but she got her brain back. So you never say never to anything in medicine. You just
Oh
do
man,
careful
yeah,
questions. So great question. I'm glad you brought that up.
yes.
And
Thank
oh
you.
my,
I
I'm
know, I know,
over
I know.
the time, so I'm going to have to do a rapid sign off here, Carolyn.
Rapid sign off. Okay, I like that. Not a hard
So
stop.
best wishes to everybody, and we'll see you next Tuesday.
Thank you, Dr. R, so much. Thank you, everybody, for being here. Enjoy and smile and be kind and be nice to you. And we will see you again on Tuesday.
Alrighty. Bye bye now.